Let's get started, and it's a pleasure to introduce our colleague Ken Simcic from Endocrinology to talk to us about a subject that certainly dear to my heart, and one that we need to be aware of in seeing our older patients with multiple comorbidities and residents of nursing homes and so forth. So we welcome you and thank you for speaking with us today.
You're welcome, Mike. It's good to be back. What I'm going to talk to you about today specifically is hyperthyroidism and hypothyroidism in the elderly. And what I did with the handouts, I just tried to give you as much useful information as possible so you can take care of these disorders with a minimum amount of input from specialists, because most of these disorders you can do most of the management yourself. And I hope this information is right for you. I hope it's not too basic, because I just wanted you to understand these disorders real thoroughly if you don't already. Now, I wanted to start with a case presentation. When I was working in El Paso with the Army before I came here, this was a real interesting guy that I saw. A 59-year-old male who was referred with weight loss and hematochezia. He had had these problems over the past 6 months, and they sent him to general surgery because they thought he had colon cancer. So they started to work up this guy, and they put him through a lot of tests. His colonoscopy and EGD were negative, to their surprise. So they said that there's got to be cancer here. This guy's got weight loss, he's got hematochezia. They did an abdomen CT scan, liver spleen scan, bone scan, they were all negative. But the poor guy was tired of being in the hospital, and they said, well, if there's no tumor in the belly, it must be in the chest. So they did a CT scan of his chest, and this is what he looked like when he was referred. A thin gentleman had lost a significant amount of weight. And when they did his CT scan, they didn't find anything in the chest, but fortunately, the cuts went up a little higher into the neck, and they found he had a goiter. That's all thyroid there. It's about 3 times as big as it should be. So they called us an endocrine to come over and see him, and the minute we looked at this guy, we said, he's got hyperthyroidism, based on his eye findings. So 2 conclusions to draw from this. Number 1, don't send patients to surgeons for weight loss work, okay? And the other thing is that hyperthyroidism in older patients does not always present itself typically like it does in younger patients. The only thing remotely sounding like hyperthyroid in this guy was his weight loss. There were no heat intolerance, tremor, tachycardia, palpitations, none of that. So a good case for us to get started with. Now, to understand hyperthyroidism and hypothyroidism, if you can understand this basic old feedback inhibition loop, you should really be able to understand most of the information about diagnosis and management. And you remember the pituitary makes TSH that stimulates your thyroid to make T3 and T4, and they feed back on your pituitary. So if your thyroid is overworking, if it's making too much thyroid hormone, you're going to turn off your TSH, and that's what hyperthyroidism usually looks like on lab tests. High free T4, low TSH. On the other hand, the thyroid stops working, you're not making any thyroid hormones, TSH is going to go up. So low free T4, high TSH, okay? And another good thing to be aware of is euthyroid 6 syndrome, and I think you're all probably pretty familiar with that, but just to review it a little bit, when patients are sick, their thyroid function tests tend to be abnormal, okay? If you're getting thyroid function tests in a sick patient, don't expect them to be normal, okay? They're rarely normal. But a lot of the changes are artifactual. A lot of the abnormalities that you see are not real thyroid problems, but they look like it. And basically, you see that the sicker you get, the more your thyroid tests change. And what I want you to focus on mainly is T3 in black, TSH in TSH in green, and free T4 in red, okay? And when you get sick, the first thing that's going to change in your thyroid function test is your T3. It's going to go down fast, and it's going to go down a long ways. But we don't usually check T3s, okay? So you don't usually pick that up very early. But the next thing that you're going to see is the TSH is going to start to drop off. You know, you can have a low TSH with euthyroid 6 syndrome. And then if you get sicker, you see that things like your T4, your free thyroxine index, however you measure that, that's going to be the final thing that goes down. And actually, that's a bad prognostic sign. If you're sick enough for your free T4 to drop, your chances of survival start, going down too. So, the reason I bring this up, one other thing I'll mention is that in the recovery phase from non-thyroidal illness, TSH will sometimes be elevated. It'll be high but less than 20. And when these patients, if they recover from their non-thyroidal illness, all these things will come back to normal. So you don't treat this, okay? But be aware that euthyroid 6 syndrome can look like a lot of real thyroid problems. It can look like subclinical hyperthyroidism. It can look like subclinical hypothyroidism. And later on, we'll talk about why that's important, okay? So just a little review on that. And again, this is what we just covered. Now, hyperthyroidism is what we're going to talk about first. And basically, I think the best way to approach hyperthyroidism is only know about the common causes, because the uncommon causes are very rare. And I would recommend that you memorize these 6 here, okay? Graves' disease, toxic multinodular goiter, solitary toxic nodule, subacute thyroiditis, iodine-induced hyperthyroidism, and iatrogenic or factitious hyperthyroidism, okay? Now, as far as etiology, Graves' disease is caused by an abnormal antibody that stimulates the thyroid. It basically acts on the TSH receptor to stimulate the thyroid to make excess hormone. So the whole gland is in overdrive. With toxic multinodular goiter, basically you have adenomas in the gland that are functioning independently and making excess thyroid hormone. And solitary toxic nodule is similar, but there's only one nodule in this particular situation. And be aware, when we're talking about these nodules in hyperthyroid patients, they're benign. We're not worried about cancer with toxic multinodular goiter or solitary toxic nodule, okay? And these are the 2 most common causes in the elderly, Graves' disease and toxic multinodular goiter. So whenever you see a patient with hyperthyroidism, if they're not being overtreated with thyroid hormone, chances are, in your patient population, they're most likely to have one of these 2 things, okay? Now, the other things that are much less common in the elderly, and let me mention that solitary toxic nodule is also fairly uncommon in the elderly. When you look at series, up to like 30 to 40% of older patients with hyperthyroidism are going to have either Graves' or toxic multinodular goiter. Toxic multinodular goiter is usually in 2nd place, but it's very close to Graves' in 1st place. Solitary toxic nodule, only up to about 10% of elderly patients with hyperthyroidism are going to have that as the cause. And with these things here, it's usually less than 5%. But be aware, subacute thyroiditis, this is an inflammation of the thyroid gland where the thyroid follicles get damaged, disrupted, and excess thyroid hormone leaks out of the gland. Iodine-induced hyperthyroidism is not real well understood, but basically if you have a thyroid gland that's already moving towards hyperthyroidism, an early multinodular goiter, or an early Graves' patient, and you hit them with a bolus of iodine, that can tip them into frank hyperthyroidism. And then iatrogenic or exogenous thyroid hormone is usually very obvious. Now, these are the uncommon causes of hyperthyroidism. Don't worry about these because as an endocrinologist, I don't even see them, okay? And as far as symptoms and signs, here's symptoms over here and signs. You're familiar with most of these. But in elderly patients, a few things to be aware of. Number 1, for some reason, elderly patients with hyperthyroidism can have pretty severe constipation. We think of that with hypothyroidism. It can also occur with hyperthyroidism in the elderly. Another thing, the weight loss is a very important finding in the elderly, but they usually don't have the increased appetite. They usually have anorexia, so they tend to lose a lot of weight with hyperthyroidism. Atrial fibrillation is the way a lot of these patients present, okay? And then with elderly patients, only about half of them are going to have a goiter when they have Graves' disease or toxic multinodular goiter. So that's going to make the diagnosis more difficult. But the main thing to be aware of, when we talk about apathetic hyperthyroidism in the elderly, about 1/3 of elderly patients with hyperthyroidism are not going to have the classic signs and symptoms. They may only have one finding, like that first patient we talked about, weight loss, or they may only have atrial fibrillation. Sometimes that's called monosymptomatic hyperthyroidism, and that's one of the biggest differences between hyperthyroidism in older and younger patients. Again, you may only find one of these things that's going to be your hint of the underlying diagnosis. Now, a good example of that apathetic hyperthyroidism phenomenon, the first George Bush, when he was president, he was diagnosed with Graves' disease, hyperthyroidism. Can anybody remember how he presented?
Atrial fibrillation?
Yeah, atrial fibrillation. That's all he had. There was no other hint of hyperthyroidism. The paper said, President has atrial fibrillation, common thyroid condition in older people. It wasn't until like 3 days later, it used to take that long to get thyroid function tests back, that they did them initially, even though he didn't look hyperthyroid. Everybody with atrial fib, new onset, should get thyroid tests. He had them done, and that's what he had. He had hyperthyroidism due to Graves' disease. So again, a monosymptomatic presentation. And it's really curious. His wife, Barbara, was also diagnosed with Graves' disease less than 2 years before he was. And that shows you how common a disease Graves is, especially in young patients, but still in older patients. It's the most common cause of hyperthyroidism in most of the series. So again, yeah.
Did you know that their dog also had hyperthyroidism during that
I thought he had lupus. I couldn't confirm that he had but I heard that he also had thyroid disease. And I remember the cartoons that Barbara and George were sitting on their sofa, and the dog was behind him drinking Perrier water. He was afraid to drink the water in the White House. People were talking about there might be some agent or toxin that triggered all this. It was really interesting. So the two of them had that same condition. What I'd like to talk about next is just the clinical features of those 6 common causes of hyperthyroidism that we talked about, okay? And with Graves' disease, what you often see is a diffuse goiter with or without a thyroid bruit. When you listen over the gland, sometimes you can hear the blood rushing through there, okay? It's difficult in older patients because a lot of them have carotid bruits, and sometimes it's hard to distinguish. But a diffuse goiter is what we think Graves when we see a diffuse goiter without any nodules and hyperthyroidism. Now, the other manifestations of Graves' disease, you can see the infiltrative ophthalmopathy, pre-tibial myxedema, and a very rare rheumatic syndrome called thyroid acropathy. And then other autoimmune diseases can sometimes cluster with Graves' disease in patients with altered autoimmune function. But with the ophthalmopathy, when you look at the figures, these are probably more like figures for younger patients, because older patients don't tend to have a lot of eye findings with Graves' disease, okay? In some of the series I saw, only 5 to 10% of patients, had eye findings. But, and usually they're fairly mild, okay? And pre-tibial myxedema, a skin change that we see on the lower legs, is only seen in about 2%, and then acropathy is very rare. Now, pre-tibial myxedema, have any of you ever seen that? It's kind of a misnomer because we hear myxedema, we think about hypothyroidism, but pre-tibial myxedema is actually a very specific dermatologic finding for Graves' disease, okay? And I'll show you some pictures of that. Now, here's a patient, an older patient with Graves' disease. She was about 65 years old. Her only complaint was weight loss. And basically on her exam, she had no goiter. You see her neck looks normal, it feels normal, but she had a high free T4, a low TSH. And on her thyroid scan, we saw the diffuse homogeneous uptake that we expect to see with Graves' disease. So again, talking about clinical features, here's the patient we started off talking about. And this guy has what we call a stare. When you see the white of the sclera above the iris, that's due to lid retraction. And lid retraction can be seen with any cause of hyperthyroidism. It's not specific at all. Hyperthyroidism tends to increase sympathetic tone. That can affect the muscles in the upper eyelid and give you lid retraction and lid lag. And here's another good example of a patient with lid retraction.
Yes.
Real nicely right here. And I've always had an interest in famous people with endocrine disorders, and Marty Feldman was a famous actor and comedian who had very severe Graves' ophthalmopathy, and you see in his case, you don't just see that white above the iris, you see it below, and usually when you see it below, that's an indicator that you have true proptosis, and true proptosis we see only with Graves' disease, okay? So again, proptosis, when you exophthalmos, they're really the same thing. When you see that, you know the patient has underlying Graves' disease. And CT scans can tell us a lot about Graves' ophthalmopathy. Usually these extraocular muscles are very thin like ribbons, but with ophthalmopathy, they become infiltrated with white cells, glycosaminoglycans, and this is what you see. And some of us think that Graves' ophthalmopathy is a vanishing disease because we just don't tend to see it as much as we used to. I remember when I was an intern, there was at least 2 patients admitted every year for high-dose steroids for severe ophthalmopathy. But, in our endocrine clinics, we rarely see severe ophthalmopathy anymore, and we're not sure exactly what the reason is for that. Hopefully it's that less people are smoking, because smoking can have a bad effect on ophthalmopathy. Now this is pre-tibial myxedema, and what it is, it's a non-pitting edema, like an orange peel type skin appearance, and sometimes it can become keratotic like you see here, sometimes it can be nodular, but bottom line, when you have a hyperthyroid patient, even though this is a rare finding, take a look at their lower legs. If you see any abnormality there, it's not just the typical edema you see with CHF. You're probably dealing with Graves' disease because this is a very specific physical sign we call pre-tibial myxedema. Okay? And so that's Graves' disease. And let's move on to toxic multinodular goiter now. Another very important cause of hyperthyroidism in the elderly. Usually these are patients who have had a goiter for a long time. It's gotten progressively bigger, and their free T4 has just gradually gotten higher and higher to the point where they're hyperthyroid, okay? And with these patients, usually you'll feel multiple nodules. You'll feel a goiter with multiple nodules on their exam, okay? And here's a typical multinodular goiter patient. She presented very hyperthyroid, tachycardic, she had some weight loss, she had some tremor. And if you look at her neck, you can see it's pretty full here, and you can kind of see the nodules that are underlying her condition here. And this is the typical scan that we see with toxic multinodular goiter. Usually the thyroid is enlarged, often pretty significantly, and we tend to see patchy uptake, hot areas, like this, and then colder areas like that. So patchy uptake is very typical for toxic multinodular goiter. And we'll talk about treating these conditions later on. Solitary toxic nodule, you find, just what you'd expect, a single nodule on exam, and it's usually at least 2 or 3 centimeters, so it's usually palpable. And there's something about solitary toxic nodule that makes T3 toxicosis more common. This is a situation where you have low TSH in a hyperthyroid patient, but a normal free T4. In T3 toxicosis, only the T3 is elevated, and that only happens in about 5% of hyperthyroid cases across the board, but a lot of them turn out to be solitary toxic nodules, and we're not sure why in this particular condition we see so much T3 toxicosis. And on scan, here's what you see. Here's an earlier stage, most of the uptake's in the nodule, it's starting to turn off the rest of the gland. Here's another patient, where you see, again, a high uptake in the big nodule, the rest of the gland almost turned off. So thyroid scan gives us a lot of helpful information in addition to our physical exam. Now, subacute thyroiditis is a really interesting syndrome. Dequervain subacute thyroiditis is the painful type. Okay, there's also a painless variety. But let's talk about Dequervain's first. And this is a condition where inflammation occurs in the thyroid that causes damage, that causes leakage of thyroid hormone and hyperthyroidism. And the etiology is probably a post-viral inflammation because a lot of these patients have a history of a recent upper respiratory tract infection. And the main thing you see on exam is just exquisite tenderness in their neck. their thyroid is very painful. You can't even examine it. They have so much pain there. And so whenever you see hyperthyroidism and neck pain, think right away about decorvate subacute thyroiditis. The thyroid's usually a little bit enlarged. In other additional helpful lab tests, these patients, they usually have a SED rate that's over 100, and the thyroglobulin is usually high because that leaks out of the gland along with the thyroid hormones. And if you do an anti-TPO antibody, it's usually going to be negative. And to show you the clinical course of these patients, it's really interesting. If you look at their T4 in black, or let's say they're free T4, they start off normal, and then when the condition begins, they have a hyperthyroid phase where their free T4 goes up. But as the inflammation resolves, it comes down to the normal range and usually dips into the hypothyroid range before it totally normalizes. So this is a self-limiting condition that almost always gets better on its own. And if you look at the TSH, it's going to be just the opposite from the free T4. So when you think about the free T4 levels in subacute thyroiditis, think about a sine wave. That's what you're going to see, the two phases, okay? And whenever you see a patient with funny thyroid tests that seem to be changing, here they were hyperthyroid 2 months ago, now their TSH is a little high, this is a condition you want to think about. And again, there's a painless variety that can be a much more difficult diagnosis, okay? Now, just some other clinical features. We talked about the painless variety. With this silent subacute thyroiditis, as we call it, similar clinical course but no neck pain. About 25% of these patients burn out their thyroid and they're left with permanent hypothyroidism. The hyperthyroid phase is often subclinical, so sometimes you won't detect the condition till they're in the hypothyroid phase, and you might think they're a typical hypothyroid patient. In the silent thyroiditis patients, the SED rate's usually normal, and in these patients, the anti-TPO antibody is positive in about 50%. So this is probably more of an autoimmune phenomenon as opposed to a post-viral. And some drugs can also give you a clinical picture very similar to subacute thyroiditis: lithium, amiodarone, alpha interferon, and interleukin. So be aware of that. Iodine-induced hyperthyroidism, this is one that's important for you to know about. Yod-Bezadal is the old name for this condition, and this usually occurs in patients who had a pre-existing goiter, either Graves' disease or a multinodular goiter that was autonomous, maybe not yet diagnosed. If they get a bolus of iodine, that can make them hyperthyroid. And as far as the iodine exposure, that's most likely to come from either radio contrast for a CT scan or an IVP, or more likely amiodarone, okay? Amiodarone is about 40% iodine by weight, so when patients get started on that, they get an incredible iodine load, and up to 5% of them can become hyperthyroid as a result of that. And the hyperthyroidism that we see with amiodarone is interesting. There's two different mechanisms. There's two types of hyperthyroidism, different types we can see due to amiodarone. The type 1 is the classic iodine-induced mechanism where they already had an underlying early hyperthyroidism. The iodine bolus tipped them over. But the other type is like a painless subacute thyroiditis type mechanism where they have a hyperthyroid phase, then the hypothyroid phase, and some of them, totally burn out their glands. Now, clinically, it can often be very difficult to distinguish one from the other. So often when we treat them medically, we'll treat them for both conditions, and I'll talk to you more about that later on. Now, iatrogenic, this is usually obvious. Patients with hypothyroidism are given too much levothyroxine, okay? There are some over-the-counter weight loss products that have animal thyroid in them, a desiccated pig thyroid or cow thyroid. You may find some elderly patients that are trying to lose weight. It's a lot more common to see that in younger patients. And we had a lady about 49 who went over the border. She was from Laredo. She went over the border and bought a weight loss preparation in Mexico. She didn't know that it had thyroid hormone in it. And she presented with hyperthyroidism and was referred to us. And she had a very low uptake on her iodine studies, and that was the tip-off. So unlikely you're going to see this in elderly patients, but you might. Now, how do we diagnose hyperthyroidism? Well, it's very straightforward most of the time. Usually you see a very low TSH. It's usually less than 0.1, and it's usually undetectable. If you have a second generation assay, it's usually less than 0.01, okay? And the free T4 is increased, all right? Now, I know over here in the VA you have the older methodology for thyroid function tests where you do the total T4. If you're using that methodology with hyperthyroidism, what you're going to see is a high total T4, a high T3 resin uptake, and a high free thyroxine index, because the FTI, the free thyroxine index, is an estimate of the free T4. When you order a free T4, it's measured directly. If this older methodology is used, then you have to calculate it from the total T4 and the T3 resin uptake, which is a correction factor for binding proteins. And you don't see this used much very often anymore. I was really surprised when I came here and saw that it was still used pretty commonly. Now, what about T3s? Well, the only real indication in all of medicine for checking a T3 level is a patient that has a low TSH and a normal free T4. Okay, there's no other reason to get a T3. Most patients with hyperthyroidism, like 95%, they're going to have a high free T4 and a high T3. So there's no need to check both. But again, that small percentage, maybe 5% with T3 toxicosis, this is the only thyroid hormone that's going to be elevated. So if you have a patient, especially a patient who's clinically hyperthyroid, low TSH, normal free T4, that's when you have to get your T3, okay? And then there's some additional lab tests we sometimes do that are helpful in hyperthyroid patients. You can measure the Graves antibody, the thyroid stimulating immunoglobulin. It's about $70 to do the test, and it usually doesn't give you much more additional information. And as we said, for subacute thyroiditis, the SED rate, the thyroglobulin can also give you helpful information. But bottom line, usually all you're going to need is your TSH or your free T4, okay? Now, what about the differential diagnosis? Now, this is very important here. I think if you can understand this, it really simplifies hyperthyroidism. If we look at those 6 most common causes that we mentioned before, you can divide them. You can put 3 in the high uptake hyperthyroidism category and 3 in the low uptake. And the uptake we're talking about is the 24-hour radioactive iodine uptake. Once you make your diagnosis of hyperthyroidism with your high free T4 and your low TSH, almost all the time, this is the test you're going to want to do next in elderly patients, okay? And what this is, basically the patients are given a small dose of radioactive iodine by mouth. They come back to nuclear medicine in 24 hours, and the gamma camera scans over their neck to see what percentage of that iodine dose is still in the thyroid gland, okay? And the more active the thyroid is, the more overactive it is, the higher percentage of that dose is going to be there, okay? And so, you can see why, these conditions are going to give you a high uptake. In all of these conditions, you have a thyroid that's basically in overdrive, either the entire gland in Graves' disease or focal nodules, as in these other 2 conditions. So these are going to give you a high uptake. On the other hand, these conditions, if you think about them, these are, like in subacute thyroiditis, that gland is sick. It's really not making any thyroid hormone or trapping any iodine. It's just leaking it. So the uptake here is going to be very low. In iodine-induced hyperthyroidism, the thyroid is already so saturated with iodine, none of the radioactive iodine can get in there. And finally, if you have too much exogenous thyroid hormone, that's going to turn off your TSH, which will turn off your thyroid gland, okay? So these are all low uptake causes of hyperthyroidism. Now, if you look in nuclear medicine, the normal range for 24-hour radioactive iodine uptake is probably about 10 to 30%. But one of the interesting things about older patients with hyperthyroidism is they don't have frankly elevated radioactive iodine uptakes. Often they're high normal, like 22, 24. Young patients, say with Graves' disease, can have uptakes of 85%, 96%, sky-high uptakes. But be aware of that. With older patients, you may see a high normal radioactive iodine uptake. And the reason this is important is all of these high uptake conditions are going to require a definitive treatment for hyperthyroidism. These conditions really don't go away on their own. But these conditions are all self-limited. They do go away on their own, so they don't require any definitive treatment, just symptomatic treatment until the condition resolves itself. And when you do the 24-hour uptake, the scan is done along with that. The scan's a totally separate test. It's the pictures we talked about before. So when we talk about a scan and an uptake, this is what we're talking about. And they do this with I-123. That's the radioisotope that they use in nuclear medicine. Okay? So we just covered this information. And what are the definitive treatments for hyperthyroidism? What treatments do we have available? Well, radioactive iodine is the one we're going to talk about most today. Also, thyroidectomy, you can do that for some hyperthyroid disorders. And then finally, antithyroid drugs can also be used. So these are the three treatments that you have available. And let's talk first about radioactive iodine, because this is going to be the treatment of choice for the great majority of your elderly patients with high uptake hyperthyroidism. Okay? It's a very safe treatment. We've used it since 1940. Thousands of patients have been treated. And they've had long-term follow-up, not 5 years, not 10 years, but 30 years, 40 years. And none of the studies have ever shown any increased risk in a patient that takes radioactive iodine for hyperthyroidism. They don't have a higher risk for thyroid cancer later on, or any other cancers for that matter. So that's something that patients are understandably concerned about when you tell them you're going to give them radioactive iodine, but it's very safe. And with elderly patients, this is an important point, because this is much different than younger patients. When we use radioactive iodine to treat elderly patients with Graves' disease and sometimes toxic multinodular goiter, we usually pre-treat them with an antithyroid drug like methimazole or PTU and a beta blocker, because sometimes after radioactive iodine is given, the hyperthyroidism can transiently worsen for a few weeks. That may be radiation thyroiditis that causes more hormone to leak out of the gland. Now, if that happens in a younger patient with a strong heart, it's usually no big deal. They just take extra beta blockers. But in an older patient with heart disease or pulmonary disease, that can tip their balance and get them really sick. So we tend to be much more cautious. Whereas in younger patients, usually we just put them on a beta blocker and hit them with a radioactive iodine right away in those younger patients with Graves' disease. Now, when we give radioactive iodine, hypothyroidism is the desired side effect. We really want to trade hyperthyroidism for hypothyroidism. And why is that a good trade for the patient? Why is it better to have hypothyroidism than hyper? Okay, the reason for that, yep. Go ahead.
Easily treat hypothyroidism.
Yeah, it's a much easier disease to treat medically. Okay, it's much easier to take levothyroxine long term than it is to take PTU or methimazole. Okay, and this is the figure we use for younger patients, that a single dose of radioactive iodine between say 8 and 15 millicuries will make 90% of younger patients hypothyroid. This is, I was just looking at some literature. In older patients, this isn't quite true. It's probably more like 50%. And a lot of older patients after radioactive iodine, whether it's Graves' or toxic multinodular goiter, their thyroid levels will come down, but often they'll just kind of stop in the euthyroid range. Whereas with younger people, almost always we just wipe out the whole gland. So, in any event, what you do after radioactive iodine, you follow those thyroid function tests real carefully to see what's going to happen. And most of the patients will get hypothyroid. It usually takes about 4 to 6 weeks to bring the thyroid levels down, so it's important to continue that beta blocker for a while. And if beta blockers are contraindicated, you can usually use a calcium channel blocker. And in general, we like that heart rate to be less than 90 before we give radioactive iodine. The other thing is you want to stop the antithyroid drug a week before you give the radioactive iodine. You want to get that out of the system so that it doesn't interfere with the radioactive iodine effect. Now, antithyroid drugs, another definitive treatment that we have. Here are the two medications we use in the United States. And the main mechanism of action of these two drugs is to inhibit thyroid hormone synthesis by blocking the iodination of tyrosine residues in thyroglobulin. Okay, so interfering with thyroid hormone synthesis. And one thing about Graves' disease can sometimes resolve spontaneously. So sometimes we will give an antithyroid drug for 12 to 18 months and then stop it and see what happens. And in less than 20% of patients, we can see a lasting remission, sometimes for years, sometimes indefinitely. Okay, So that's one difference that we see with Graves as opposed to the other two types of high uptake hyperthyroidism. So again, a course of antithyroid drugs is an option. Now, as far as side effects in these drugs, minor side effects are seen in about 5 to 10% of patients, like rash, GI upset, arthralgias, okay? The major side effects are what we worry about. Fortunately, they're rare. The one we fear most is agranulocytosis, where the white count can just bottom out and they can get serious infections. That happens in less than one half of 1% of patients that take these drugs. Allergic hepatitis occurs in about 1%, and a syndrome of vasculitis and polyarthritis occurs in about 1 to 2%. So again, when you use these drugs, you have to be aware of this, and the most important thing is you have to tell the patients, if they get a fever, if they get a sore throat, they need to stop the drug and give you a call or get into the emergency room to get their CBC checked, okay? And this is one of the problems with long-term treatment with an antithyroid drug. Anytime these patients get a fever, they need to panic, and get it. Most of them just have a virus, but again, it's that they need to come in and get that checked just to make sure, all right? So those are the antithyroid drugs. And advantages, we like methimazole because it can be given once daily as a single dose. And it looks like there's probably less of a risk of agranulocytosis when you use a low dose, like less than 20 milligrams. The main advantage of PTU is that in addition to blocking thyroid hormone synthesis, it also blocks T4 to T3 conversion. Usually this is not real significant, but in situations like thyroid storm, where we want every possible effect we can get, then it does become a consideration. So most of the time we go with methimazole because of the single dose. PTU, you need to give it at least twice a day, and you really should give it about 3 times a day. Surgery, we don't do surgery very much for hyperthyroidism, but it is the quickest cure. However, there's always at least a small risk of thyroid storm, so these patients need to be pre-treated, ideally, with antithyroid drugs and beta blockers before the surgery. And the most common complications, permanent hypoparathyroidism, recurrent laryngeal nerve injury. If you have a good surgeon like we have here with Dr. Richards, your combined risk for these complications should be well less than 5%. Okay? So what about specific therapy for the hyperthyroid disorders that we've talked about? Well, again, the high uptake causes are going to require a definitive treatment. The low uptake causes are self-limited, symptomatic treatment until the condition resolves itself. For Graves' disease, I-131 is almost always a treatment of choice. We talked about pre-medication. We do consider surgery for Graves' disease under unusual circumstances. One of them is those rare cases with moderate to severe ophthalmopathy. There's pretty convincing data that radioactive iodine may worsen the course of ophthalmopathy if it's moderate to severe. So in some of these patients, we think about thyroidectomy. Another option is to give them prednisone for a few months after their I-131. Rarely we find a cold nodule in a thyroid gland with Graves. In that situation, we worry about cancer, and surgery becomes a higher consideration. Toxic multinodular goiter, again, radioactive iodine is usually the treatment of choice. Now, in older patients with toxic multinodular goiter, about 50% will be hypothyroid after I-131, the other 50% will be euthyroid. Surgery is a consideration for these patients if they have a very large goiter with obstructive symptoms, because the I-131 is very good at bringing the thyroid hormone levels down, but it usually doesn't do much as far as shrinking the goiter. These are usually long-standing goiters that have been around for a long time. There's a lot of fibrosis and cyst formation, so if it's very large and the patient's fairly healthy, surgery is a consideration. A solitary toxic nodule, again, a high uptake cause of hyperthyroidism, radioactive iodine, usually the best choice in older patients. Thyroid lobectomy is a valid option if you have a very big nodule and you have a good surgeon available. But again, radioactive iodine is usually what we're going to recommend. Now, subacute thyroiditis, the most important thing, make the diagnosis, give them beta blockers until they're euthyroid, calcium channel blockers if these are contraindicated. If they have deeper veins, you give them nonsteroidals for the pain. Very rarely, they may need prednisone for severe refractory pain. Iodine-induced hyperthyroidism, you stop the iodine if you can, but you can't always do that with amiodarone. And even when you stop the iodine, it may take 8 months for the iodine-induced hyperthyroidism to resolve. So usually what we do, again, there's those two mechanisms we talked about. PTU is the best treatment for the typical iodine-induced hyperthyroidism. Prednisone is the best treatment for the subacute thyroiditis type mechanism. But often what we do is put patients on both and just see how they do, okay? And sometimes it can be very difficult to control their hyperthyroidism. And in those situations, thyroidectomy becomes a very valid option. It's, if the patient's, well enough and you have a good surgeon, they go in and take that thyroid out, you can keep them on their amiodarone, and sometimes that's just the best way of all to treat this condition. But the most important thing, if you suspect iodine-induced hyperthyroidism, get us involved. Consult endocrine, because it's always a complicated thing, and we'll be more than happy to provide our expertise in those cases that you get. Okay? And iatrogenics, stop the thyroid hormone, beta blockers until euthyroid. One other thing I'd like to cover before we go on to hypothyroidism, subclinical hyperthyroidism is something you hear about more and more, and I think it's really important in elderly patients. And we define subclinical hyperthyroidism as patients with a low TSH, a normal free T4, and a normal T3. Okay. Now sometimes we can get additional information from a 24-hour radioactive iodine uptake. If the Graves antibody is positive, that can be helpful, but every time I check it, it's negative. It just hasn't been helpful for me in these situations. Now obviously, if you see things on exam like goiter, ophthalmopathy, atrial fib, you're going to be a lot more serious about this. And I think the main question with this condition is it really subclinical hyperthyroidism, or is it something else like euthyroid 6 syndrome, or a medication like prednisone that can lower the TSH, okay? So the diagnosis can be difficult, especially in the setting of non-thyroidal illness. So what more can I tell you about this? Well, what are the other causes of low TSH and normal free T4? We talked about euthyroid 6. Drugs like steroids, dopamine, salicylate can lower the TSH, so it's important to look at the medications. Resolving subacute thyroiditis, if you catch them as they're resolving that initial hyperthyroid phase, their labs are going to look like subclinical hyperthyroidism. And if they have this condition, though, what you want to do is just follow it until it resolves itself. Don't think about giving them a definitive treatment. Secondary hypothyroidism can give you a low TSH, sometimes a normal free T4. It's usually a lowish free T4. And then, as always, lab error. Usually, when you get those abnormal thyroid function tests the first time, you want to repeat them just to make sure they're for real. And acute psychiatric disease may lower the TSH in some patients. So think about this differential before you start thinking about treatment. Now, the causes of subclinical hyperthyroidism, usually it's an underlying autonomous multinodular goiter that's trying to transition into a toxic multinodular goiter, not quite there yet, or a patient with early Graves' disease. And as far as complications, the thing you hear a lot about is that the risk of atrial fibrillation in these patients is increased about 3-fold compared to patients the same age with a normal TSH. And there's also data that suggests that the mortality risk is higher in patients with true subclinical hyperthyroidism. And it looks like the increased mortality is cardiac and cardiovascular. Cardiac ischemia, arrhythmia, CHF, cerebral emboli from atrial fibrillation, hip fracture. So that's why this condition is important. It may be a condition with significant health risks. Now, what are your options for subclinical hyperthyroidism? Well, basically, you're either going to treat it or you're going to follow it, okay? And your treatment options are going to be either methimazole or a preemptive dose of radioactive iodine. Try to correct the condition early. And since some of these patients have very low uptakes, it can sometimes be difficult to get them treated with radioactive iodine. One treatment that's been used recently is to give human recombinant TSH that we usually give for thyroid cancer patients to augment the uptake of I-131 in these glands with early hyperthyroidism. But I think the best way to approach subclinical hyperthyroidism is if the diagnosis is secure, then treat it. Okay, and again, we can help a lot in that regard if you want to send a consult to us to evaluate the patient. Okay, so you'll be hearing about this condition more and more. And this is the graph that you often see, the increased incidence of atrial fibrillation in elderly patients with subclinical hyperthyroidism. These are patients over 60 years of age, the percentage of them with atrial fibrillation in this particular study. And you see in patients with the low suppressed TSH, the prevalence of atrial fibrillation was about 3 times what it was in the patients with a normal TSH. Patients with a TSH in between had prevalence of atrial fibrillation that was also in between. So, this may have a lot to do with those early suggestions of increased mortality in patients with this condition. Okay. Now, what I'm going to talk about is hypothyroidism next. This is a lot simpler than hyperthyroidism because the treatment's pretty much the same no matter what the cause. But hopefully I can give you some helpful additional information. Hypothyroidism is extremely common in elderly patients. If you look at women over 55 in different population studies, you'll see a prevalence of 5 to 15% of patients with hypothyroidism in the United States. Similar figures in Great Britain. Now, 3/4 of these cases are mild, what we call subclinical hypothyroidism. We just talked about subclinical hyperthyroidism, now subclinical hypothyroidism. And what this condition is, patients with a normal free T4, usually a low normal free T4, and a slightly elevated TSH. Most patients with hypothyroidism are female, and 99% of cases of hypothyroidism that you see are going to be primary. Okay, those patients with pituitary disease that have secondary hypothyroidism, comparatively rare, and usually they have an obvious history of pituitary disease. Now, hypothyroidism, it's so common, it's so easy to treat, only atypical cases require referral to an endocrine specialist. And this is a condition that you should be very comfortable in treating on your own. The most common cause in the United States, Hashimoto's thyroiditis and autoimmune disease. Now, Hashimoto's is a chronic thyroiditis. We talked about subacute thyroiditis, totally different condition. With chronic thyroiditis, there's no hyperthyroid phase. These patients, they have gradual destruction of the thyroid and slowly progressive hypothyroidism to the point where they're permanently and severely hypothyroid if you don't treat it. Okay? The other most common causes of hypothyroidism in our country, patients that have been given radioactive iodine for Graves' disease, we call them post-ablative hyperthyroidism. And again, that shows you how common Graves' disease is. And then patients that have had thyroidectomy, either for thyroid cancer, suspicious nodules, or obstructive goiter. Okay. What's the most common cause of hypothyroidism worldwide? Yeah, iodine deficiency is still the most common cause. And the symptoms of hypothyroidism, you're very familiar with these. And one thing to notice, these are very nonspecific. When patients get on the internet and look this stuff up, they are convinced that they have hypothyroidism. Before they even see you, they come in requesting the levothyroxine prescription. But the point I always make is if you walk into an internal medicine clinic, a geriatric clinic, or even this room, and you say, put up your hand if you have any of these symptoms. Put up your hand if you have one of these, 2 of these. You see how nonspecific these are. Okay? And again, a lot of older patients have those symptoms for other reasons. Now, diagnosis, usually straightforward, high TSH, low free T4. Again, in the subclinical cases, the free T4 is usually going to be low normal. And other tests are rarely needed. You don't need a thyroid scan. You don't need an ultrasound unless you feel some significant abnormality on the exam, like some dominant nodule, which is extremely rare to feel. All you need is your TSH and free T4. Okay, don't get a T3. There's no reason for doing that in this clinical setting. Now, the question of outpatient screening comes up, and there's different opinions about this from the different thyroid and medical organizations. I think it's the ACP that says women should be screened for hypothyroidism at age 35 with a TSH and then have that repeated every 5 years. The older women get, the more likely they are to have hypothyroidism. So, a lot of, you can really justify screening older women more frequently than this. Okay? Now, just to show you, why that T3 is not helpful, if you look at a patient who's evolving hypothyroidism from Hashimoto's thyroiditis, this is the normal range for all these lab tests. You see, the first abnormality is your TSH is going to be high. Okay, this is subclinical hypothyroidism right here. TSH is a little bit high, free T4 is still normal. Okay, as they progress, the TSH gets higher and the free T4 drops into the low range. You see, the T3, since it's the more active of the thyroid hormones, that level is preserved till the bitter end. So that's not going to fall until way out here. So there's no real sense in checking it and spending the money on it. Now, there's other lab abnormalities you can see with severe hypothyroidism: hyponatremia, anemia, high cholesterol, and high CPK. So, be aware, hypothyroidism is a secondary cause for hyperlipidemia. Before you put anybody on a statin, you should at least check their TSH, okay? Because what they really might need is just some levothyroxine. Some hypothyroid patients will present with total cholesterols over 300 and then come down to 200 after you treat them with levothyroxine. Now, as far as treatment, very straightforward, hormone replacement with levothyroxine, okay? Synthroid is the brand name that you usually see. There's Levothyroid, there's Levoxyl, and a lot of generic preparations now. This is essentially a perfect substitute for human free T4, for human thyroid hormone, okay? And what's great about it, it's got a very long half-life, 7 days, so you can give it as a single daily dose. And we tell patients, hey, if you forget it one day, just take 2 doses the next day to make up for that. Since the half-life is so long, they can do that, okay? And the great majority of thyroid hormone that comes out of your thyroid is T4. Most of the T3 is made by conversion in the liver and the kidneys. And for that reason, using pure levothyroxine is very physiologic, because you give them all T4 and they physiologically convert it to T3 in their liver and their kidneys. Okay. Now, side effects are only going to occur if you overtreat the patients, or in the rare situation where they have an allergy to the color, the dye in the tablet. And hypothyroidism is so common that levothyroxine is the 4th most frequently prescribed drug in the United States. So I'm sure that you see a lot of your patients that take that. As far as initiating therapy, let's say for somebody with moderate to severe hypothyroidism, somebody whose TSH is 15 or higher, what we usually do in older patients is start with the smallest tablet, 0.025 milligrams. Let's say the TSH is 40. We know that's not going to be enough, but especially if they have underlying heart disease or lung disease, we want to just see how they respond to it. So we'll put them on this lowest dose for 2 to 3 weeks. If they don't have any problems with it, we'll bump it up to 0.05 milligrams a day. Then at this point, you can either wait 6 weeks and check your thyroid function tests again, or you could consider bumping it up to 0.075 before you wait 6 weeks and check your thyroid levels, okay? And basically what we do to get them euthyroid, we increase their thyroid hormone in increments of 0.025 milligrams per day and check their thyroid function tests every 6 weeks or so until we get a normal TSH. When the TSH is normal, we'll recheck it in about 4 months. If it's still normal, at that point, they only need yearly follow-up. They only need a yearly blood test. So hypothyroidism, we tell patients, we're going to get this better for you, we're going to cure it, and it's going to become a very low maintenance problem once we get you on the right dose, if they're compliant, of course. Okay, and I think the 2 mistakes that are most frequently made in the management of hypothyroidism are either the dose is changed by too much, or the provider does not wait a full 6 weeks before they check the thyroid function test again. So you really, once you change the dose, you really need to wait a full 6 weeks before you recheck the levels. And usually, if you need to increase the dose or decrease it, usually you only need to use this increment here. All right. Now, other aspects of levothyroxine treatment, a situation that comes up pretty commonly, a patient's been on the same dose of levothyroxine for a long, long time, and their TSH has always been normal, but suddenly it's high. They're on the same dose, but the TSH is now, say, 28. The first thing you want to think about is non-compliance, because in the great majority of cases, that's going to be what's going on. Other things to consider, there are some drugs that can affect thyroid hormone dose. You don't see Questran and cholesterol used much anymore, but they can interfere with the absorption of thyroid hormone. So ask the patient about new medications. This has also been reported with iron sulfate, soy products, and calcium carbonate. Now, it's possible maybe they really do have an underlying malabsorption disorder, celiac sprue or inflammatory bowel disease. That's unlikely, but it's possible. And celiac sprue can sometimes have a minimum of symptoms. Sometimes you can see severe malabsorption of levothyroxine with no weight loss whatsoever. So that's something to think about. We don't give much estrogen out anymore, but estrogen increases thyroxine binding globulin. So if you have a patient with hypothyroidism who's on the right dose of levothyroxine, they may need more after estrogen is started. And then there are certain drugs that increase the metabolism of levothyroxine. Those are listed here. Be aware of those. Okay, so that medication question is one you always want to ask. Hypothyroidism is almost always permanent because it's usually caused by Hashimoto's or surgery. You can see reversible hypothyroidism. You know, we talked about resolving subacute thyroiditis, and then certain medications can also give you reversible hypothyroidism if you're able to stop them. And lithium, okay, I think we're going to mention that later. Now, what about subclinical hypothyroidism? A lot of questions come up about this. You got a patient with a TSH of 6.9. Okay, normal goes up to 5.5. Their TSH is just a little bit elevated. Their free T4 is usually low normal. Do you treat that or do you follow it? Well, I think the best thing to do is just wait 2 months, repeat the thyroid function test before you do anything. And then, you know, usually you're going to follow them every 4 to 6 months if the TSH is still elevated at less than 10. So 10 is an important cutoff that we use. As long as they're less than 10, you know, we're going to follow them. But if that TSH goes up to 10 or greater on 2 consecutive tests, then we usually say it's time to start levothyroxine. And we start at the lowest dose since it's a mild degree of hypothyroidism. Now, if that TSH remains in that 5.5 to 10 range, you know, we follow it unless these circumstances are present. Okay, if the patient has a goiter or a positive anti-TPO antibody, then they likely have Hashimoto's. It's going to progress. So you might as well get them on treatment now. Okay, and then if they've had any history of radioactive iodine treatment for thyroid problems, thyroid surgery, radiation exposure to the head or neck, or medications like lithium and amiodarone that can cause hypothyroidism, you might as well go ahead and get them started on treatment because it's likely that the TSH is just going to go up higher since they've had some insult to their thyroid gland. And then finally, I think for psychiatric patients, I have a very low threshold for treating them and normalizing their TSH because as long as that TSH is even a little bit elevated, the patient's psychiatrist worries about depression, the patient worries about it, and likewise, a complicated medicine patient with a lot of medical problems and complaints, usually it's best to just start a low dose of levothyroxine, normalize the TSH, and simplify the management. Bottom line is, if you're going to treat, don't over-treat, okay? And I think basically, you're going to have to follow most of these patients for 6 to 8 months or so before you're sure that they have subclinical hypothyroidism. Most of the time, when you reach that point where you have a firm diagnosis, it's perfectly reasonable to treat. Just don't over-treat, okay? And I didn't make those points strong enough, but lithium and amiodarone are important medications as far as hypothyroidism. Amiodarone, since it's got all that iodine in it, it can cause both hyperthyroidism and hypothyroidism. They say about 5% of patients on amiodarone get hyperthyroid, about 20% get hypothyroid. So if you have patients on that particular drug, it's a good idea to check their thyroid tests at least every 4 to 6 months. And if their TSH starts going up, usually you can't stop lithium, usually you can't stop amiodarone, so we just treat them with thyroid hormone, okay? And the risks of overtreatment of hypothyroidism are basically the risks of hyperthyroidism: cardiac arrhythmias, cardiac ischemia, and bone loss, okay? And I think with that, I'm going to wrap it up. I'll let you read the rest of the information in the handout, but if you have any questions about this, I'd be happy to take those questions now.
What is the natural history of hypothyroidism? Is a person gonna... We see a lot of patients in the gym clinic that are on like 0.025, 0.025 would be the lowest dose of Synthroid, have been on it for years, and there's question as to whether maybe they're inappropriately on it.
Yeah.
Would you expect them to be on a somewhat of a higher dose if they're truly?
Yeah, when
hypothyroid?
you treat patients initially with subclinical hypothyroidism, usually you're going to go with a lower dose. But you would expect that with time, that's going to progress and they're going to need more thyroid hormones. So that is kind of surprising when they've been on it 5 years and they're just on that low dose. And you might be able to stop it. Some of those patients, they may have been diagnosed prematurely. Again, maybe they had subacute thyroiditis, they were recovering, and when they got started on the thyroid hormone. So, and then you look at your TSH too. If the TSH is like lowish, then for sure, stop that low dose, see if they really need it.
By
Yeah.
low issue would mean like 1 or less than 1 maybe, as opposed to
TSH,
closer to 5.
I'd say less than 3. If somebody's on 0.025 and their TSH is less than 3, they probably don't need it. So that's what I recommend for that. Yeah.
Could you comment on the pregnancy and the hypothyroidism? What is the main
Yeah, the important thing about pregnancy is that when a woman's hypothyroid, she's on the right dose of levothyroxine, when she gets pregnant, you see the same effect as starting estrogen. Since endogenous estrogen levels go up, thyroxine binding globulin goes up. Suddenly there's all these empty sites on thyroxine binding globulin that bind that hormone. So that patient's going to need a higher dose of levothyroxine. And what we find is about 50% of hypothyroid women, when they get pregnant, they're going to need an increase in their thyroid hormone dose. And it's usually going to be an increase of about 0.05 milligrams, okay? And then, when the pregnancy's over, within a few months, you can get them back on their regular dose. It's just a matter of that thyroxine binding globulin. And a study you hear a lot, when they looked at pregnant women with elevated TSHs, even a little bit elevated, they found that when you looked at the children later on at about 5 years of age, they had some mild intellectual problems. And so with that study, there's been a lot of emphasis on trying to keep those TSH levels normal throughout the pregnancy. And I think you can make a good case if a hypothyroid woman gets pregnant to just preemptively, bump her dose by 0.025. Check her thyroid test, but even while you're waiting for them, bump her dose up a little bit, because it's such a predictable thing with at least 50% of them that that's what you can do. So, anything else?
I think your point about not jumping in to treat TSHs between 5 and 10 immediately is especially well taken in the gem clinic. Sort of the patients that Mark is talking about, who for whom the decision was to be made much earlier whether or not to treat. I suspect a very large percentage of those patients whom we see a lot of do not progress anywhere, and especially in the older population where there are some there are more likelihood of having so-called circulating anti-idiotypic antibodies that may interfere with the TSH assay and may actually falsely elevate it. So I would agree fully with following a patient like that over time and seeing if they develop an increase in the TSH.
Some of the papers have said, with since you can get high cholesterol with hypothyroidism, subclinical hypothyroidism may increase your cholesterol and cause an increased risk for heart disease, and that's a good case for treatment very early. But the studies really haven't proven that yet. When you hear different, sides of that, but we still don't have proof that treating these patients in this early stage of hypothyroidism is beneficial. So again, I think the most helpful thing you can do is just follow that patient. Usually, after 6 to 8 months, they might normalize their TSH. It might be frankly elevated over 10, or you may see it steadily trending upward. And and that would be a pretty good reason, to go ahead and start treatment. So I think with either subclinical hyperthyroidism or subclinical hypothyroidism, again, once you have a firm diagnosis, you can go ahead and treat them. But usually you need to take some time before you have that firm diagnosis. And again, your physical exam can be helpful. If you're feeling a goiter in that subclinical hypothyroid patient, that's going to make you think more about treatment. If your subclinical hyperthyroid patient has some eye findings or a goiter, likewise, you're going to think, hey, this is probably early grades. Let's just treat it early. So I think that's a practical approach to those problems. Yeah.
Quick question. Patients that are overtreated with L-thyroxine, how do you decrease the dose dependent on how low the TSH is and how fast do you?
Yeah, you know, what I do, if they're overtreated,
Yeah.
you know, what I will often do, since the half-life is a week, is have them don't take any for like 5 days, especially if that free T4 is frankly elevated, like 2.5. You know, I'll say don't take any for 5 days, and then you reduce their dose, and it kind of depends on some things, like, you know, sometimes they've just been taking the wrong dose. You know, in that case, you know, you want to decrease it a lot to the dose they should be on. But, you know, most patients, you know, if they're, you know, a little bit, if their TSH is low, you know, you could either go down by 0.025 or 0.05. I think it's just a matter of looking at that TSH, and that's where the free T4 can help you. You know, if you only have money for one test in a thyroid patient, TSH is going to be the best test. But it's nice to have that free T4, because when you look at the two of them, usually you can get a much better idea of how to manage them. But, you know, especially with hypothyroidism, when we make a change, you know, it's usually the 0.025 is increases, you know, all we have to do, you know, at a time. You know, 0.025 at a time is usually all we'll do, especially in elderly patients. And, you know, and I think you know, we're probably overcautious to a great degree. You know, I should have mentioned it with well, you know, with young patients in hypothyroidism, we put them right on a replacement dose. There's a little formula. You know, if their TSH is 40, you know, you can start them on anywhere between, you know, 0.1 and 0.15 milligrams of levothyroxine, straight on a replacement dose. But with older patients, you know, over 50, especially if they have heart problems, we tend to start with those real low doses, 0.025, or, you know, you can sometimes start with 0.05. You know, we're probably being overcautious for the most part in doing that, because I have seen very few elderly patients, you know, respond poorly to higher doses. But, you know, that's still the standard of care in endocrine, to start low and increase it slowly, you know, when you're treating an elderly patient with hypothyroidism. And if they have documented heart disease, obviously that's especially important to start at that low dose. Anything else?
Ken, thank you very much.
Thank you.
I know why you said it.
Yeah, all right.